and very grateful for this opportunity to talk about something that I have a lot of interest in and spend a lot of time in. Before I get started, I don't have any disclosures. I do receive grant support and research support from EpiCal, as mentioned. And I want to mention one other thing. I have a language disclaimer. In this talk, we're going to be using or discussing some terminology from the DSM from the past, which actually isn't used anymore, but for the sake of education and getting folks kind of up to speed on the history of the DSM, I think it's helpful. So I just wanted to give that trigger warning, I guess, or disclaimer. I also want to mention something I learned from the LEND program, which is, I'll talk about what that program is that some people prefer person first language while others don't. And so it's just important to respect whatever the individual's preference is. In this talk, you'll hear me kind of use one or the other interchangeably. And you'll often hear me use the word individual over words like patient, client, service user, participant. And that is like my own effort in reducing unhelpful power dynamics in medicine. So if you hear that, that's why I'm doing that. So today I'm going to talk a little bit about the evolution of autism and psychosis spectrum disorders in the DSM. We're going to talk about three different diagnostic overlaps and two distinguishing features, how you might be able to distinguish these two from each other. And then I'll also cover some programmatic or treatment adaptations that could be made to support this population. All right, so a little bit about me and why I'm here. So I, many years ago when I was a medical student, I adopted a dog named Ozzy from a local shelter, and he was highly recommended to become a therapy dog. And so from the shelter, they supported us in doing some training. I got a scholarship for him to take the Pet Partners course, and he became certified. And we used to visit a local forensic inpatient psychiatric unit and an inner city safety net hospital. And this was around the time when the DSM-5 TR had just come out. And I remember at that time, there was a lot of discussion around having to redo the diagnostics for individuals that were living on those units. And people were beginning to think about about diagnosing autism for some of the folks that had been there for a long time. I just want to mention that one of the reasons I'm here in psychiatry is because of Ozzy, because of all the amazing experiences I had with him and seeing how individuals interacted with him, and just the therapeutic potential of pets in psychiatric settings. When I went on to do my child psychiatry fellowship, I was interested in early psychosis. I knew that was what I was going to do. But I noticed I was struggling with this intersection of autism and psychosis. If I had a child who had a neurodevelopmental condition of some sort, or a genetic condition, or even autism, I was really struggling at understanding or conceptualizing how psychosis was different from that, and vice versa. We sometimes would see kids who had an established first episode, but then who I began to wonder, do they have autism underlying all of this? So my amazing program director at that time encouraged me to do a one-year training program called the LEND program at UC Davis at the Mind Institute. And there I spent a whole year focusing on this intersection, doing a lot of evaluations and doing multidisciplinary evaluations at the Mind. I want to acknowledge that this intersection is not always easy. It's sometimes tough from a diagnostic standpoint. And it's not always straightforward where one diagnosis begins and the other one ends, and vice versa. So I want to acknowledge and really encourage you all to imbibe humility. Humility is very important. I think not getting stuck on one diagnosis or another. As children get older, things evolve and you may get to learn more about them. And so being willing to adapt and being flexible is very important. I also want to acknowledge that a lot of healthcare providers develop this understanding of psychosis that's really influenced by and with adults who have chronic in the outpatient setting. On top of that, adult providers receive very little training on assessing and supporting people with autism. Usually that's like deferred to the pediatric providers. And so based on this, a bias could emerge where one might experience prognostic hopelessness related to psychosis and autism. I think it really comes down to people's anxieties and feeling like they don't have the skill set to support them. And then that might translate into feeling like this person's never going to get better, which is simply not true. And then on top of that, psychiatry residency programs, and even other training programs are often not affiliated with psychosis programs where you might be able to develop a hopeful recovery-oriented lens, because you would be working with individuals who are doing well. And then on top of that, not all programs have peer specialists who experience this intersection, or may not even have a peer support specialist. And so I would encourage you all to challenge that. I have been humbled in my work in my clinic in Child Inspire. So for some context, I work with around 60% of the population that gets care in Child Inspire. These are kids who experience either clinical high risk for psychosis, or have had a first episode of psychosis, or multiple episodes of psychosis. 60% of them have co-occurring autism. So many of them also have catatonia. And every time I open the literature on this topic, it's very depressing. And I came out of training with a little bit of a bias, not knowing that, like, oh, people can actually do really well. And so I wanted to highlight this because we had this milestone event at our Inspire 360 wraparound coordinated specialty care program, which was celebrating people's milestones. And these are just some of the milestones that some of the kids had. Many of them didn't write it on there because they're too humble. And I was like, guys, you need to brag a little bit. Y'all have done amazing things. And some of these kids also have co-occurring autism. So I think that it's just really important not to make assumptions about how far someone will go, what is their max potential, and just keeping that open mind and walking that journey with them with that open mind. All right, so let's jump into an evolution of the DSM. And here's the trigger warning, and I apologize for some of the language from the past. So back in the day, a psychiatrist by the name of Broiler coined the term schizophrenia, and this was like back in 1907 when he began using that term in Zurich. I think he like formally presented it in 1908 or published it at that time. And he noted 4 core features of schizophrenia related to association, affectivity, ambivalence, and even he used the word autism. And he defined autism as this detachment from reality and having a predominance of their inner life. Since then, things have evolved with the DSM. We're going to kind of briefly go over these, but you all will have my slides to be able to look and read through some of the specific criteria. So we'll start with DSM-2 back in 1968. This was a category that was characterized by alterations in concept formation, which led to misinterpretation of reality and sometimes delusions, hallucinations. Sometimes kids, they would describe them as being withdrawn, having some level of regression or change or bizarre behavior. I will mention that in 1968, they also had a specifier for schizophrenia called schizophrenia childhood type. And this is literal language from the DSM-2. This category is for cases in which these symptoms appear before puberty, and it may be manifested by autistic, atypical, and withdrawn behavior. General unevenness, gross change, developmental changes, right? Not meeting those milestones. And it could be associated with an intellectual disability. And so if you read this and you look at our autism criteria now, there's a lot of overlap here. And so and I'll talk about why that's very important after this. Moving into the DSM-3, this is when childhood onset pervasive developmental disorder entered. And so this was sort of moving towards what we now call autism, but essentially there were changes. So difficulty with change, they called it sudden excessive anxiety, and meltdowns essentially is what they're describing, having constricted affect, difficulty with change, different motor movements, walking on tiptoe, having differences in speech, having sensory differences, and then self-injurious behaviors. But to receive this diagnosis, you could not have delusions, hallucinations, or loose associations. And then the DSM-3 revised said that essentially if someone was previously diagnosed with PDD, and then later on developed psychosis symptoms that were consistent with the DSM-3 schizophrenia diagnoses, then they could no longer have this diagnosis of PDD. So that developmental disorder piece of it would have to go away from their list of diagnoses. And this had really negative impacts for people, especially those who had developmental differences. They lost a lot of access to important services that helped support them. And now these individuals were eligible for participation in research studies, especially schizophrenia research studies. So this wasn't that long ago. I mean, this was 1987. And so that's very important to keep in mind, because now we had people that were just moving forward with the schizophrenia diagnosis, even if they had a co-occurring neurodevelopmental condition. In 2000, the DSM-4 entered, and Asperger's disorder entered. And this is also, again, they added this specifier where you could only make the diagnosis of schizophrenia if the person had prominent delusions or hallucinations. I will mention in 1994, this is also when the DSM people or the powers that be realized they made a mistake. And so they said that, okay, actually you can have both pervasive developmental disorder and schizophrenia. From 87 to 94, people really struggled, and then they again flipped it so that folks could get both, because we don't use it as much anymore. In DSM-5 in 2013, this is when autism entered. And so autism is, as we know it now, is characterized by deficits in social communication and interaction, having restricted repetitive patterns of behavior, interests, or activities. Also having sensory changes is a big one. You might hear this word stimming, and this is short for self-stimulatory behavior. It refers to the repetitive movements, sounds, or actions that people with autism might use to regulate sensory input, manage their emotions, or express themselves. And it really varies from person to person, and some people don't have a lot of stimming. So that's just something to keep in mind in case you hear that from individuals that you work with. I will also mention that autism is often missed in some populations, especially girls who are able to socially mask. And so in the DSM, they have this language. These symptoms might be present in the early developmental period, but may not fully manifest until these social demands exceed their limited capacities, or might be masked by learned strategies later in life. So we see a lot of women later in life who have been struggling with this for a long time and then don't get diagnosed until they're an adult. There's also social pragmatic communication disorder. In the interest of time, I'm actually not going to go over this, but I do have, it's another disorder or diagnosis to be aware of as it relates to the autism spectrum and schizophrenia. As we think about schizophrenia now, if someone has a diagnosis of autism or a communication disorder of childhood, like social pragmatic, then you only make the diagnosis of schizophrenia if the person has prominent hallucinations or delusions. So that's very important to keep in mind as you're thinking about the diagnostic differential. And then with the DSM-5 TR, APS, or attenuated psychosis syndrome, has entered. And this is for individuals experiencing psychotic-like experiences that are below the threshold of full threshold psychosis, but higher than maybe what we would consider in the normal range. And those experiences might be distressing or impactful. So I went over all this history. I spent like 10 minutes talking about this. Why did I do this? For a lot of reasons. One is that the DSM has a lot of power. It shapes how we define and track mental health. It can change prevalence rates. It can also update who qualifies for certain types of care. It can also reduce stigma or pathologize certain types of behavior. Most importantly, it impacts research samples and treatment development. It affects how we think about prognosis and outcomes. And that's a really big one. When you read about early onset schizophrenia, early onset psychosis, every time I read one of these meta-analyses that include studies like from the beginning of time, a part of me dies inside, because I know that they are not taking into account the evolution of the DSM and how we have defined autism and how we used to define childhood onset schizophrenia. So I would advocate, if you are a researcher, keep this in mind. Try to pick studies that are DSM-4 onwards, preferably, so that we are not repeating the same mistakes and not making inappropriate assumptions around prognosis and outcomes because these populations were so mixed before the DSM-4. So this is what psychosis is. This is per the DSM. And these, to be classified as psychosis, these experiences have to cause some level of distress or difficulty functioning. I want to acknowledge that psychosis looks different for each individual. And there's some common experiences among people, but I will say no two people are going to present in the same way. There can also be cognitive changes, and that can impact a lot of different things, but cognitive changes vary from person to person as well. We think of psychosis and even autism, kind of similar to autism, as occurring on a spectrum, right? And so on the left side here, we have experiences that are less distressing, less impactful. A good example of that is like sometimes I hear my phone ding and I look at my phone and no one has texted me. There's actually no notification, but I thought I heard something. So congratulations, I just had a little psychotic-like experience, didn't cause me to really get very distressed or impacted. I moved on. There are also some experiences that are developmentally normal, right? Kids who have imaginary friends, or things that are within cultural norms. For example, if families who have religious or spiritual beliefs and how those experiences are had. Then there's some experiences that we label in the APS or clinical high risk range. These are, some experiences that are there that are happening, but maybe not causing the person to get extreme distress or be extremely impacted. And then we have full threshold psychosis. This is what we would label as a first episode of psychosis. So experiences that are highly distressing, highly impactful. I want to mention that even people with full threshold psychosis can also have experiences on the spectrum lower down as well. So it's important to keep that in mind. And when we are thinking about evaluating these experiences, I'm mostly interested in the ones that get in the way of things. I will ask, like, when they mention certain experiences, do they get in the way of stuff? Do they cause you worry, concern, or distress? And do they impact what matters most to you? Again, that kind of goes back to the SIPs or the mini SIPs and the way in which we assess psychosis symptoms. I want to also mention that sometimes psychosis is at the forefront of why someone is coming to you for care or seeking out support. And sometimes I would say it's the thing that takes up the most in that person's life. But sometimes it's not. Sometimes it's other things actually that are bothering this person. For example, trauma symptoms or medical things or stigma or autism. And so it's very important to listen to what the person is coming forward with. What are the things that they want in their care, and really making sure you are honoring and centering that, and not just assuming that any concern that they bring up is chalked up to psychosis or autism. I want to mention that the autism is also a spectrum. And I tried to find a really good picture, and this was probably the best one I could find, in that we know that no two people with autism are the same. And it makes it such a joy to work with each one because each one is so unique and they have cool things that they like, that they're interested in. And I like learning about those things, especially the things that they want to talk about. So for example, I have kids in my clinic who know everything about vacuums. I have one kid who can tell me the latest and the greatest in Dyson technology and why I would want to buy one over the other. I find that cool. And so when he tells me about it, I'm learning from him. And I find that creates that shared experience. And it really helps me. So I think, being open to learning about the things that people are interested in can be really helpful, not just for them, but actually more for you too. You might learn something working with them. I also want to mention that actually autism, people are going to have differences along some of these things. This is not all encompassing for autism, but it just highlights kind of the different things that they may have differences in. When we think about autism, when you read the literature, when we think about the DSM, it's very much focused on people's deficits. And I will say that can be very harmful. Imagine coming to a medical visit or a mental health visit, and every time they're focusing on your deficits, not highlighting your strengths. That can be really harmful, right? It's demoralizing to go in and everyone's focusing on the things that you're not doing right. It's important to acknowledge that people with autism do have unique strengths, and two things can be true at the same time. They can have strengths and differences. And so your job is to get to know them and be curious And I give slide credit, we use this in our California Learning Collaborative, co-developed with me and 2 other amazing individuals. So let's talk about this diagnostic overlap between autism and psychosis spectrum. And I'm going to go kind of criteria by criteria. So I'll start with hallucinations. On the left side, you'll have kind of the psychosis definition of hallucinations. And on the right, I've listed features of autism that might resemble that core domain. So for people with autism, they might have changes in sensory and their sensory perception. They might be hypersensitive to some things or hyposensitive to things. They may also have difficulty differentiating from their inner monologue, which is actually developmentally normal, right? That inner voice that is a perception of your own thoughts, actually, it could be. Sometimes people have a hard time telling if that's an intrusive thing or not, or a foreign external thing. And some may also have difficulty even expressing that internal experience, depending on where they're at with their speech skills. There's also scripting, where kids with autism might be saying things that they heard in a TV show, in a song, the conversations that they heard. They're recalling that script. It's almost like they're reading like a script and playing the scene over. And unless you know that person and know the content of the show that they've watched or whatever it is, you might inappropriately label that as them talking to themselves. So it's very important to really know this person and understand them. There might also be behaviors that look like they're prompted by having hallucinations. So they might go and walk up to a door and check something. And if you don't know why they did that, you might inappropriately label that, oh, they're responding to internal stimuli. And then they also have changes in eye contact, right? If they're always looking up at the corner, not making direct eye contact with you, you might inappropriately assume that they're having maybe visual hallucinations, for example. Let's talk about delusions. So individuals with autism may have overvalued ideas or eccentric beliefs that really govern their life. They may have certain ways of thinking and they like adhering to that, and they have no problem with the way in which they are following their belief system. They also may be experiencing excessive fears or phobias. We see this a lot in little kids with autism who get they have one fearful experience and then they really want to avoid that thing always. Like for example, bugs is a big one. Seeing a bee, knowing that there's the potential of getting stung, and then being like totally frightened every time they're, around outside and nature and potentially going to be stung by a bee. They may also have restricted interests that you may not know about, and you might inappropriately label that as a delusion if you don't know that it's a longstanding interest that hasn't really caused them problems until whenever they're coming to see you. That's important to keep in mind. They also might have social anxiety that resembles paranoia. I will say, like, middle school and high school is an attack on the senses. First of all, kids are stinky, they're intrusive, they're loud. For people with autism, that may not be the most fun place to be. And then on top of that, the social dynamics really get intense around that age. And people with autism, because they might have difficulty interpreting social cues, they might get anxious. They also might have a history of being bullied, and that might be contributing to their social anxiety. So we want to really make sure we understand what has happened with this person and get a sense of their history. We also want to think about social differences. So misinterpreting social cues, right? Sometimes some people feel that people are making fun of them when actually they're just misinterpreting the cue. Disorganized speech is a tough one. So by the way, if you catch me on a day that I'm post-call, I'm going to have a little bit of disorganized speech. It's just the nature of life and our brains when we're sleep deprived. So for this symptom to actually fall into the psychosis spectrum, the speech symptoms have to be severe enough to impair effective communication. And when you're working with individuals, you really have to understand their speech at their baseline before determining, is this unusual or a change in their speech? And for people with autism, they might have existing verbal communication differences. They may also not want to talk about the things that you want to talk about. And so it might look like they're giving unrelated answers to your questions when really you're not going with their flow. You need to go with their flow a little bit. And they may also or repeating what people are saying. Disorganized behavior can manifest in a lot of different ways. We have catatonia as one of them, and there's slowed types, there's excitatory types that can fall into this. People with autism, I think often people struggle with this because they don't understand, for example, on inpatient psychiatric units, when you have somebody with autism on that unit, it can be really difficult to assess, are they having disorganized behavior because of psychosis, or are they overstimulated and this is not the right environment for them? And it looks like they're very disorganized, but really they're just stimming, or maybe they're pacing around, maybe they're having a lot of hand movements because they're stimming. They may have difficulty with change that leads to an expression of distress. And if you don't know that person, hey, that kind of change is known to cause, some distress, then you might inappropriately label that as disorganized behavior. Also knowing that their greeting rituals might differ. Like they may not come up to you and shake your hand and say hello. They may have a different way of saying hello. So being mindful of that. Negative symptoms is like carbon copy. This is not a great way of determining whether someone has psychosis. So I just want to acknowledge that there's a lot of overlap with many other mental health and even medical conditions, and same with autism. I will mention that one thing to keep in mind around negative symptoms is that people with autism, we don't want to label things as them having low motivation in general, because they may have low motivation in doing certain activities or preferred activities. So keep that in mind. They may also appear anhedonic when really they just express themselves differently than others. And they, some at their baseline, actually aren't interested in social interactions. And so not labeling that as a problem is important. Also, you have to really understand their baseline. I have one thing about negative symptoms, which might be spicy, but that's okay. I'm okay sharing it because I think it is important to share. And I credit Dr. Nev Jones for really kind of opening my eyes to this idea for the first time. One thing is that we have to think about when someone is living with a mental health condition or even even autism, they experience a lot of different things, right? Some experience involuntary care. They have a lot where they lose their sense of agency. And then as they are going through the system of care, there's many ways in which the system crushes these people. And there are structural policies that I think keep people impoverished. And unfortunately, if you are faced with that repeatedly, anyone in their situation might shut down, might not be interested in doing things, and that might look like negative symptoms. So when you're working with people, you really want to be identifying if they're developing learned helplessness, and do everything you can to really build up their sense of agency, give them opportunities, and advocate for change in our society and in the ways in which we can change public policy as well. All right, let's quickly go through evaluation, and then I'm going to open it up for questions. So one is you don't want to miss the medical workup. Just because someone has autism or has a history of psychosis doesn't mean you turn off your brain and don't do medical workup when it's indicated. If someone's coming in with fevers, vital sign changes, they've had multiple infections recently and suddenly are having a change in their behavior, you better do a medical workup. When I do these evaluations, I try to get as much history as I can. I look at everything in the chart. I ask families to bring in genetic testing if their child already has a diagnosis of autism, and I look at that genetic testing because a lot of kids may have gene mutation changes that are tied with psychosis, and that can be really helpful. You want to look at prior reports. You want to get collateral. You always want to screen for trauma. Every single kid that comes through our clinic gets a trauma screener. That's very important. And then you want to start with a broad differential. I mentioned the gene mutations. There's a lot of them. So pay attention to that. And don't, if the gene testing was done more than 2 years ago, pull up PubMed, look at the gene to see if there's anything new that we know about that gene. Sometimes you might work with people who are non-speaking. And so I would encourage you all to offer every opportunity for that young person or that individual to provide independent responses to your questions. Do not assume incompetence. So if they have an AAC device, make sure they have that available to them. as you're going through questions. If they don't have that, you can use things like physical gestures, like yes or no, maybe using fingers to quantify severity in terms of the experiences you're screening for. And you may need to dedicate additional appointment time. These are not the 60 or 90-minute appointments. These are the 2-hour ones potentially. I mentioned this because we are learning that there's a lot of kids who were seen as being intellectually disabled who weren't, who had medical things or, a history of non-speaking autism where they just weren't able to communicate. And so Viraj Dunda is a great example of this. I encourage you to check out his story if you haven't read it or aren't aware. But he talked about when he got his AAC device, it was very liberating. The simple dignity of being able to speak was enough for him. And he is the first individual with autism who's non-speaking, who is going to MIT this year. When you're gathering history, again, you're getting a lot of things. You want to really understand this person's background, their cultural background, their developmental history, environmental factors. What are the social factors as well? How do you diagnose it? So there's a lot of overlap. I just spent like all that time talking about, oh gosh, look at all this and how it overlaps. So first is you want to ask yourself, what is this person's baseline? In terms of speech behavior, their interests, their ability to take care of themselves on a day-to-day. You also want to understand what was the nature of the symptoms that are being reported. Is this a change in their baseline or behavior, ADL, social behavior? Is there any change in their ability to care for themselves suddenly or gradually? And then what was the time course? And then per the DSM, you also have to be thinking about, are there prominent hallucinations or delusions? You cannot just rely on disorganization symptoms. And then if they are having hallucinations or delusions, are these distressing or impairing? Then you also want to think about, many kids come in with exposure to antipsychotics. Maybe this was a child that was already on an antipsychotic for autism-related irritability. And then maybe we tried to adjust that. Did it lead to an expected response? Meaning, did we see improvement? If you didn't, that's a clue into maybe what might be going on. How do you diagnose a psychosis in someone with autism? So again, if they have to have new hallucinations or delusions that are lasting over a month, and in some ways, they're maybe having some difficulty now telling what's a common perceptual experience that everyone has and what's something that's only happening to them, or having a change in their functioning that's like dropping. And then I think in addition to that, being mindful of trauma, anxiety, mood disorders, which can parallel the onset. We know that people with psychosis are at have co-occurring PTSD at much higher rates than the general population. So make sure you are also screening for that, not missing the trauma side. A lot of things you could be thinking about in the psychosis differential. This is not a full list, but here's some things you might think about. What about the flip side? How do you diagnose autism in someone with psychosis? So first, you got to get history from multiple sources if you can. If usually kids, we are talking with the caregivers and maybe the school, the pediatrician. You are going to get a very thorough developmental history. You want to know all of the milestones. You want to understand what their social behavior was from like infancy all the way up to where they are now. You really want to understand their history of trauma. And you may want to consider using screening questionnaires. This can be very helpful. And there's a bunch. I like to use both subjective screeners for the adolescents. So I'll give the teens the RADS-R to fill out because I think it gives me a sense of what their experience is like. I also will give parent caregivers also some screeners. And then you also want to consider formal testing because if there is autism happening, some insurance companies won't provide services unless they've had formal testing through like something like the ADOS. When you do diagnose either autism or psychosis or both, I encourage you to promote a hope-filled and recovery-oriented lens, right? We really want to be challenging some of these negative biases or stereotypes towards these two conditions. You also want to acknowledge that double stigma might exist, and you want to provide hopeful examples of what's possible. And these are photos from my yard when I grew monarch butterflies. And I really feel like a lot of the kids that come to me are like in this little cocoon. By the time they get to me, they've been through a lot of systems of care, either ER visits, inpatient units, residential, and they really started to shut down because they're scared. Families are scared too. And I love seeing them flourish, seeing them come out of their cocoon and be free in pursuit of the things that are important to them. When you've diagnosed something like autism and psychosis, you have to be thinking to yourself, can they access an early psychosis program, which is evidence-based? It improves outcomes. A lot of programs don't, and that's a shame. I would encourage you to think about eligibility and thinking about expanding access. You also want to think about if they're a regional center recipient or if they're receiving autism-specific services, can they still get it after the psychosis diagnosis? Or are they going to start falling through the cracks because both systems are now saying, nope, you are not our problem and you're not our problem? And can that family and that individual navigate two systems of care? That's a tough thing to do. That's not easy. Like even for me personally, if I have two different doctors in two different places, good luck trying to remind me to come to my appointments on time. So I really advocate for breaking silos and working together. As if you're in an early psychosis program, or if you're in an autism program, or if you're a school, thinking about collaboration, cross collaboration, offering co-management. One is that people can offer early intervention, so screening for these things. If you're a psychosis program, screen for autism. If you're an autism program, screen for psychosis. We want to catch these people early, not wait until they're, in crisis or when they enter adulthood, and we've had so many missed opportunities to support them. We also want to think, I would encourage programs to amend their eligibility criteria to reflect the realities of the population. A lot of early psychosis programs have been developed to support research interests. They want this really pure research, and that doesn't always do service to the community. You also want to think about if you're a program and you're noticing, hey, we don't really have an autism expert, or we don't really have a psychosis expert, seeking out staff trainings on this. And you may even work with your local early psychosis program or your local regional center to get those things. And then doing outreach to schools and advocating with young people in your program, both at the systems level, but also sometimes at the school level. Sometimes, schools are doing a lot. They have a lot on their plate. And I will say not all schools have experience working with students who have psychosis and autism. Like that intersection is tough for most people. So working with them can be very helpful. And you also will learn what's happening at the school level in that child's natural environment. So make sure that you are touching base with whoever are their touch points at the school to understand what's happening there as well. These are some different program adaptations. There's a lot of different ones you can think about. I work in a program where we're very lucky. We have an OT. I think that is a game changer for people living at this intersection. And we do field visits. Like our team will go out in the community and meet folks to work on different things. And then you also want to, again, reduce eligibility exclusions. You also want to think about how do you engage support persons? How do you, one, educate the person's support system in terms of what autism looks like and what psychosis looks like, and then making sure that everyone's on the same page in terms of what that individual's goals are. I would advocate also thinking about your physical spaces from a sensory standpoint. Are these inclusive, or are these an attack on the senses? When you're designing groups, are you allowing people with autism to join? And making sure that you have adaptations to the group design or format. And then lastly, I'll mention medication and health management. These are just a couple of the things. There's a lot of things I do, but for example, with some of the kids that I work with, when I'm thinking about medications, if I have a kid who can't easily tell me whether they're having antipsychotic-induced akathisia or they're stimming, before I even start the antipsychotic, I try to get some baseline data on how many steps they take. So I know, are they pacing now suddenly after I started Abilify? I also think about medication. We do a lot of clozapine in our clinic. And if this is a young person who has poor interoception, can't really tell me if their belly is hurting, or if there's pain in their body, or if there's chest pain or shortness of breath, I add on additional lab monitoring for myocarditis in those first 4 to 6 weeks. I like to have objective data when I'm working with that. And then being mindful of the sensory sensitivities as well. All right, I have some gratitude. I'm very grateful for all the people who have helped me along my journey into specializing in this topic, but most of all, I'm most grateful to the young people and the families that I have the privilege of working with and witnessing their journeys while living alongside psychosis.